Hypersensitivity reaction. So there's autoantibodies that are made against either the basement membrane in the kidneys, or the renal glomerular basement membrane, or the pulmonary alveolar basement membrane. And from some sort of injury, there's exposure of the basement membrane and antibodies against type 4 collagen. I spelled that wrong. I'll fix that. Sorry. Okay, so this is just the pathophysiology behind it. So there's injury to the vasculature of the lung in the alveoli, and as well as in the glomerular basement membrane. So there's antigens that form antibodies when there is exposure, like some sort of injury that causes capillary leak, and then that attacks the basement membrane, and that can affect both the lungs and the kidney. So that can cause all the symptoms that we saw in that case: oliguria, hematuria, proteinuria, and pulmonary hemorrhage. And that can lead to the patient having renal or respiratory failure. So the risk factors that can cause this is somewhat idiopathic, but things that can be risk factors causing injury to the lung and kidneys are smoking, exposure to organic solvents or hydrocarbon fumes, metallic dust, cocaine inhalation. Different lung infections can predispose you. Things that are immunosuppressants, like some of the MABs, and there is a genetic risk as well.
Do you know what that medication's for?
That one, no, I don't know which one that
for
one is.
For chronic lymphocytic leukemia and multiple sclerosis.
Okay. So people with the HLA subtype DR15 and DR4 are apparently at somewhat of an increased risk genetically. So the clinical manifestations of risk factors are fatigue, weakness, lethargy. Some people get nausea, vomiting, lots of appetite, and they look unhealthy. Sometimes people have a dry cough, and the dry cough can end up leading to hemoptysis, so you're coughing up blood. Some people have shortness of breath, a hard time breathing, burning with urination, and sometimes people see blood in the urine or foamy urine with protein, and then you can get swelling of your hands and feet, and some people get elevated blood pressure with it as well. So diagnosis. On physical exam, things that people see are that the patients come in with an elevated blood pressure and signs of fluid overload, so there's swelling in their hands and feet, or when you listen to their lungs, it sounds a little wet. On urinalysis, you see blood and you see protein in the urine, and sometimes erythrocyte casts, so the bloody casts. And creatinine can be elevated if there's renal involvement. When you do serology, anti-GBM antibodies should be present in the patient's serum. And on imaging, people do chest x-ray, and that's when we see the diffuse hazy opacities, which are nonspecific, but it can be a sign of hemorrhage. And immunofluorescence, so when you get a biopsy of either the glomerulus or the alveoli, and you can see the appearance of IgG deposition throughout the basement membrane, so it lines the whole thing. So this is a picture of normal lung on the top left, and that shows the normal alveoli. And so you can see the sacs are lined, but then when there's hemorrhage due to this disease, then you can see that there's blood all in the middle. You can see all the red blood cells filling the sacs. The pictures on the bottom left, that is also showing the lung in immunofluorescence, and then you can see it on the right. When people have this disease, there's everything that's lighting up in green is the antibodies. Okay, and this is just an image on the left. There's the chest X-ray, and on the right is a CT of what it looks like when you have diffuse pulmonary hemorrhage. So you can see all those hazy opacities. It looks a little cloudy, and on the right, the part that's not dark, like over here. Can you see my cursor?
Yep. No. Well, actually, no. Yeah.
Okay.
And I can see. Yeah.
All right. So in the center, that could be the blood. So complications of Goodpasture, people can end up getting chronic kidney disease and stage kidney disease. They can get respiratory failure, rapidly progressive glomerular nephritis, and severe pulmonary hemorrhage. So it impacts the lungs and the kidneys a lot.
So you're going to get a blood test for an anti-GBM antibody, but you're going to biopsy the kidney if you can. Okay. Yes, if you can safely get the lung tissue, that's fine. But usually people it's more accurate to get a kidney biopsy. Okay.
Okay.
But what in your differential diagnosis? How are you going to exclude these other diseases?
Right. So some of the other ones like Wegener's, that's another one that can affect these. Those ones. So Wegener's, you would have C ANCA positive, and you wouldn't have the anti-GBM. And right. For like polyarteritis nodosa, that's a P-ANCA one. So there would be different tests that you do for these other ones.
Okay.
What I saw a patient in the hospital, and I followed him for quite a while, and he actually had overlap. Have you ever seen anything like that, Tony? He had both.
We had a Church-Strauss guy who completely bled out all over his lung. He got an open lung biopsy. Nobody saw anything, and then they threw everything up. We got steroids, Cytoxan, rituximab, and then completely recovered. And then goes to India, comes back, and he's dragging his heel, in the office. Hi, Dr. I'm great. I'm feeling good, blah, 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 blah. And then I biopsied his sural nerve, and he had Church-Strauss.
Yeah.
Extravascular eosinophils and granulomas. Yeah. So yeah.
I had a guy who overlapped. He had both anti-GBM and C-ANCA positivity. And he had respiratory failure, renal failure, and he got treated for basically everything, and he did well for some reason. But there is an overlap between some of these entities.
Right. So you don't necessarily right. You get a P-ANCA with Goodpastures. You get a P-ANCA with Church-Strauss. Occasionally in Wegener's you get a P-ANCA, even though you're looking for a C-ANCA.
Right.
So yeah.
Right, there is overlap.
There is overlap, yeah.
Okay.
Okay, so then I had a treatment slide. So things that are typically used for treatment, combination of corticosteroids, immunosuppressants like cyclophosphamide and plasmapheresis are used. The corticosteroids help suppress the immune system. It antagonizes the arachidonic acid pathway because your immune system is hyperactive in the situation. And immunosuppressants like cyclophosphamide and rituximab.
Cyclophosphamide definitely is an effective drug.
Right, I saw that cyclophosphamide and rituximab are both.
Yeah, well, that's what I was going to say. It's a very, very difficult drug to tolerate long term. It's got many, many complications, including hematuria, bladder cancer, blood dyscrasias, and there are other drugs. After you get the patient under control, there are other drugs that have been tried, including methotrexate. But the rituximab, there's a study called, the acronym is RAVE study, R-A-V-E, I believe, where they used the rituximab, and it was as effective as Cytoxan in the initial treatment of disease. So, Cytoxan is that's the standard, the old standard. It's a very difficult drug to tolerate. So rituximab is really the darling now.
Yeah, that's what I was reading when I was looking online. It seems like that's the direction that people are going with this.
And when you say corticosteroids antagonize the arachidonic acid pathway, do you know what it's making?
So that's like the COX-1, COX-2.
Yep. So it's shifting to an endocannabinoid prostanoid, future endocrinologist. So, and that actually is a neuroprotective anti-inflammatory protein that will crosstalk with leptin signal. So it's what they call it. It's a non-genomic anti-inflammatory switch. the arachidonic acid pathway. Very good. So have you ever seen a Goodpasture patient, or you're just reading up on?
I did see one when I was in medical school. I haven't seen one here.
Okay.
Never.
How did that patient do?
That patient ended up needing dialysis. So, I think that was long-term for the patient, so it wasn't the best outcome.
Great.